Okay, I think we can start the presentation.
Good evening, my fellow colleagues. I'm Jeng Yeng. So today we'll be talking about prospective CT coronary angiography. So this is my outline. We'll be briefly going through cardiovascular disease, diagnostic tools, focus more on patient preparation, scanning techniques, challenges and limitations, and last will be our case sharing. So cardiovascular disease is a class of disease that involve heart and other blood vessels, including CAD, angina, myocardial infarctions, stroke, hypertensive heart disease, congenital heart disease, peripheral artery disease, and venous thrombosis. And this is a research done in Macau in year 2017. It stated that cardiovascular disease has become the top 3 health killer in Asia. And in our clinical practice, we see more male patients than female patients. In risk factors, family history plays a vital role in cardiovascular disease, and following by aging and other lifestyle habits like smoking, high cholesterol, obesity. In diagnostic imaging, we aimed to detect coronary plaques and calcifications, artery stenosis, to see any reductions in coronary perfusion, myocardial perfusions, and also evaluate the anatomical structures. Diagnostic modalities for cardiac scanning, mainly we'll be talking about MRI, because we believe that MRI can see ischemic cardiomyopathy, and it's non-invasive, no radiation involved, and it's very good to see perfusion, viability functions, and it has very high spatial resolution. And yet there's a little drawback because it consumes more time for the scans, and also it's more difficult to get slots. Let's take a look at another modality, which is the DSA, the coronary angiogram. It is still the gold standard for CAD evaluation. It has a real-time and serve for both diagnostic and therapeutic service, and yet it's invasive and requires a longer recovery period for our patients. And so our CT. Since 1998, clinical interest in CT for cardiac scanning has actually started. And it evolved from 16 slides to 64 slides. And in 64 slides, we actually scans a lot of patients, but we still meet some challenges in it, including patients with heavy calcified plaque with high calcium score, patients with stent inserted, probably the stents are heavy metals, high heart rates patients, arrhythmia patients, patients with bypass graft, and they are obese. And we see our manufacturers have done a lot of good work, settings in both software and hardware, using these key parameters is just to create an ideal CT cardiac scanners for us. And I think that these 3 parameters that we should look at, and which will help us in our scanning. First is spatial resolution, which we are looking at very small structures, but at the same time, we want it to be accurate. For example, that we have here is our coronary artery vessels, which is our LCA. And it's proximal. the diameter is about 5 mm, but then its distal is about 1 mm in diameter. And most of our stents in the market, the smallest lumen that we have is about 0.3 millimeter. If you want to check whether there is a restenosis in this such a small lumen, I think it's quite difficult. But with a machine that has high spatial resolution, we can actually remove most of the blooming artifact from all this heavy calcified plaques and heavy metal stents. And most of the CT scanners at the market, in the X and Y axis spatial resolutions, they have done very well. But in Z axis dimensions, I think there's room for improvement, because it is at 0.5 to 0.625 millimeters. But I think it is good enough, and it actually helps in diagnostic accuracy. Secondly, which is the most important parameters that we always talk about when we do CT, is temporal resolution, because we are focusing in freezing the motions of our coronary arteries. For all machines, we have specialized cardiac reconstruction algorithms, which it will only scan half segment in 180 degrees projections to get enough data for the image reconstructions. For typical gantry rotations, for all machines, is range about 250 to 230 milliseconds. And when we do cardiac, it goes into half segments reconstructions. The temporal resolutions will go down to 63 to 135 milliseconds. But still, ideally, we hope it could get 50 milliseconds to freeze all the motions for our coronary vessels. But I think this is a combination of other things, including beta blockers to slow down the heart rate, and also choose good cardiac phase for reconstructions. In the market, we have single source CT and dual source CT. Single source CT uses half gantry rotation time, which is half segments, to acquire images for cardiac. And for dual source CT, because they have two tubes, the tubes will position 90 degrees to each other and to get sufficient data. It cuts down the temporal resolution, the scan time, to a quarter. With the combination of high pitch, it actually helps a lot in CTA scannings. But of course, single source CT, we have another algorithm to use, which is the segmentation. Other than half segmentations, you can choose 2, 3, 4. Even now, we have 5 segmentations to use, which will cut down the temporal resolutions the lowest about 35 milliseconds. And it helps a lot in mild arrhythmia patients, and we need to do fast scans to capture the optimum cardiac phase. But little drawback is the scan time may increase as we increase the segments. And third will be the longitudinal Z-axis coverage. In the past, most of our CT scanners detector size is about 3 to 4 cm, which is not enough to cover the whole cardiac, because our cardiac anatomy length is about 12 cm to 14 cm. And because of that, most of the patients, when they do cardiac scans, they need to hold breath for a longer period. And as the table moves, the image captured, and because of the patient may release the breath, maybe probably beat by beat, when they move, they may have misregistrations between steps. And the images are maybe inhomogeneous in the contrast volume. But now we have 16 slice detector size to cover the whole heart in just a single heartbeat. This is the steps artifacts which we have when we use 64 slides. You can see the inhomogeneous contrast field throughout the heart, and also the misregistrations between the steps as the table move during the acquisition. So what we're using in our center is Canon, a Coilum 1 vision. It has a 78 cm wide bore, 300 kg coach capacity. I think most of our machines in the market will have similar characteristics. Just now we mentioned about spatial resolution, z-axis. It goes down to nearly about 0.5 millimeters, which is quite good for small vessels diagnostic value. And temporal resolutions range between 35 milliseconds to 138 milliseconds, depends on the heart rate. If the heart rate is slow, it uses half segments and it goes to 138. But if we use more segments for the high heart rates or arrhythmia patients, it will go down to 35 milliseconds. Fast tube rotation is about 0.275 seconds. And it has a 16 cm detector size coverage, which can cover the whole heart. And for dose reductions for our patients, it has a software called Adaptive Iterative Dose Reductions 3D, which they will calculate from the AP and lateral scanogram. But for CCTA, the sensitivity is at 95% and specificity is at 87% because in heavy plaques, heavy calcified plaques patients and patients with heavy metal stents, they may cause blooming artifacts and it may affect the results and the diagnosis. Advantages of using such machine, of course, it increases the scan, it speeds up the scan time. It covers more areas in just one scan. Reduce bleeding artifacts, of course, reduce the sedation used for our PITS patient. And of course, the amount of contrast needed for injections is reduced as well. When we moved from 64 slides to 320 slides, the acquisition time definitely is reduced by a lot. And we can put our ROI, instead of ascending aorta, we can put it at descending aorta because it's fast enough to catch. The bolus tracking threshold, we can set at the coronary enhancement threshold at 300 Hz per unit. Most of the scans, you can use prospective. The coverage at 16 cm, no table movement is needed, and the contrast use is lesser. And this is the CT scan room in our hospital. So when it comes to patient, we always check if the patient is pregnant, because we don't scan pregnant lady or pregnant woman. For hyperthyroidism patients, I think we leave to the clinicians to decide whether there's a need to do and whether the patient is very severe that it cannot take a lot of iodine injections. And for patients who have severe adverse reactions, we try not to do. If the patient has anaphylactic shock before this or laryngeal spasms, we should avoid. And for high heart rates and high BP arrhythmia patients, I think we will answer this at the end of the presentation. Patient preparation, nearby mouth for at least 4 hours. No smoking, no caffeine intake, because this will affect the heart rate. And we always check patients' kidney function level to make sure patients safe for the scans, avoid the chances of AKI. Always check patient history because this will help us in our protocol selection, including blood pressure, cholesterol level, smoking history, diabetic, family history, CAD, stroke, diabetes, any surgical history like PCI, bypass, or others, and any medications taken like beta blockers or Viagra so that we can decide whether we should give GTN. And continue with our patient preparation. We definitely need 18-gauge Brenella inserted at the right antecubital vein. But if it's not possible, then we will use 20-gauge for a small size patient. Always measure patients' blood pressure, pulse, and SpO2 start to check out if the patient is a good candidate. Always check needle placement test to make sure the patient and the line is good. Always inform our patients about the reading instructions and also the sensation of our contrast injections so that they are mind prepared and they will not get too nervous, which will affect our heart rates. And so continue with our ECG leads, ECG electrodes placement. Make sure we had a very good contact, ECG and electrode contact. Always choose the best channel with highest RR peak. And we can monitor the patient's heart rate when they do the breathing rehearsal. And for our machines, we have this impedance test to ensure there's a good electrode contact. We start with scanogram. And if the patient has done PCR or CABG bypass before, then we will skip the calcium score, go straight to CTA. But if not, we will continue calcium score and then CTA. And here I will focus more on calcium score. In the past, we always look at a Gaston score that whether it's more than 400 to define the patient, whether it's a critical patient. But now the newest research stated that it is not a Gaston score that tells the critical, whether the patient is critical, but the location of the plaques in the calcium score. If it's at the proximal, the ostium of the vessels, it is considered as critical. And advise to give GTN if it's possible, sublingually, before the scan. If you're using tablets, always give before you start. If you're using spray, then you can give after the calcium score. But because most of the machine now are very fast to finish in the whole procedure, probably about 5 minutes. So you can give prior to the scan as well. And we need to do the auto breathing test so that the machine will choose the best phase to scan. If the heart rate, for our machines, if the heart rate is 50 to 75 BPM, definitely we choose diastolic. But if the heart rate is below 50 and more than 75 BPM, preferably we'll open 35 to 80, or you can open 40 to 70 to cover the best systolic and diastolic phase so they don't miss. And because the mid RCA has a higher velocity and the displacement of the position is greater, so advisable you still open up the phases for scanning. We use bolus tracking in our machine with dual phase injection, means we'll inject contrast and chase by saline. And for CTA cases, we always use higher iodine concentration contrast, at least 350 and above, to make sure you have enough of the iodine flux to get good arterial enhancement. If the patient is bigger size, then you can give higher injection rate and give more contrast volume. We set our RI at descending aorta because the breathing movement is loud and triggered at 300 Hz per minute because the optimal enhancement for coronary is about 250 to 300 Hz per minute. After the scan, always check the vital sign, always check the patient is fine and they have no adverse reaction. If the patient has, then you have to carry on with some medication administration, and always observe the patient for late adverse reaction as well. So for post-processing, first we must know the anatomy. The three main vessels, RCA, LAD, and LCX. RCA comes up from the right coronary sinus, goes into the right AV groove. And for the LAD, it comes up from the left coronary sinus to a left vein and divided into LAD, and it goes into the anterior interventricular groove. And for LCX, it's from the left main as well, and goes into left AV groove. So there are 3 post-processing reconstruction that we will do. The first is 3D volume rendering of VRT. For VRT, it's actually for the purpose of interventional procedures like DSA, so that the doctor will know the anatomical structures of all the vessels, and you can position your images. You can record your images according to the needs of the cardiologist. And these are some images that we do following what the plans are for the coronary angiogram. Secondly, we can do curve planar reconstructions. This is mainly to see the lumens, whether it is any plugs inside, whether it's for the stents, whether it's restenosis, and see if the reconstructions is further needed. If it's needed, then you need to do MIP. MIP mainly done by our cardiologists or radiologists to see the extensions of the vessels and the relationship between the 3 vessels. And sometimes you have accessory vessels as well. And this is a video to show how our procedure is done. It was a little bit quick, but I will explain throughout the video. We'll scan the scanogram in AP and lateral and plant our custom score. Do the breathing exercise, breathing tests to make sure the heart rate is stable. And in 1 beat, we get our custom score result, put into our software to check the Gaston score and check the position. Set our ROI for bolus tracking at the descending aorta, and give the GTN. We'll set our cardiac phase after the second breathing test. And you can choose different modes to scan, but usually we'll choose prospective because there is a arrhythmia rejection. And start the injection and scan together. We'll monitor. Once the ROI hits 300 hertz per minute, it will automatically scan. Okay, because it was fast just now, so I have captured this to explain further. So this is a breathing test, which is to monitor if the heart rate is stable. The machine will always allow a plus minus 10 BPM. Means if your heart rate is 61, the lowest to go down for the machine is 51, and the highest will be 71. There is always a gap for the machine to evaluate if the patient is suitable to continue. And here you can see the beat on the left lower. You can see this, because this patient is quite stable in the heart rate, and the heart rate is below 65. So it chooses a half segment reconstructions. And of course, you can choose other protocols to use, but mostly we choose prospective. You can also choose CTA, CFA moderate, as some doctors, they wanted to see the perfusion or the cardiac motion. So you don't need to have so much dose for just a viewing. Then you can choose moderate means you only scan full dose in the cardiac phase that you really need to reconstruct the images, and the other low dose for the other phases for the doctor to see, to view. And this is an image to show our cardiac contrast enhancement is actually enough to define and evaluate our coronary vessels. So I believe all the challenges and limitations that we have in most CCTA cases is the breathing artifacts, motion artifacts, whether the patient can cooperate, or sometimes from some minor movements, grooving artifacts from heavy calcified plaques or stents, and blurring stair steps artifacts from arrhythmia patients. So let's share some cases that we have done in our centers, and I think it's quite interesting. This is a 35-year-old male, have no family history of diabetes or hypertension. He has chest pain on and off. Lipids profiles and ECG shows normal. So after he came for the scans, and we found out this patient has an RCA ostium compressed by ascending aorta and pulmonary trunk. And when he exercised, he felt the chest pain. So this is a MIG images that we did. And you can see that this right RCA ostium is compressed by the pulmonary trunk and also the ascending aorta. We define this as an anomalous origin. It can be in RCA or LCX. Some people think that that's quite normal to have anomalous, but actually we should really look into it, because we call this as the malignant cause, which when the patient has exercised a lot, or they're doing some tensions and others, they have a higher risk to have exercise-induced ischemia and will cause sudden death. And anomalous origins has become the second most common cause for sudden death. So case number 2 is a 50-year-old female, perimenopause, is a marathon athlete, suffering from chest pain for months, and the ECG is normal. So when the patient for scans, and we found out that the patient has an LAD myocardial breach, which is partially compressed by the heart muscles. We always heard about myocardial breaching. In the past, there's less than 5% of people is diagnosed because you cannot see in the coronary angiography so well. But as imaging improves, a lot of people come for CT scans, and we found that that is 25 to 30% of patients that they report with chest pain because of myocardial breaching. And myocardial breaching most of the time appears in LAD and very rare in RCN or LCX. In systolic, we see the myocardial tissue that will compress on the coronary segments. But in diastolic, the caliber seems to be very normal. And because of this, some patients, because they can classify into superficial bridging, myocardial bridging, or a deep myocardial bridging. Some patients who have the deep myocardial bridging, they really suffers from ischemic heart disease. So we should really look into it. Case number 3. This is a 90-year-old female who suffers from arrhythmia. You can see from the ECG that we have done in our auto breathing test, the highest goes to 120, but the lowest goes to 30 BPM. She had PCI done in 2007. Is a very restless and incorporate patient. She's given with we are given beta blockers for her, but it doesn't work out so well. Informed our cardiologists and radiologists, and they still say that we need to proceed the scan in order to know that what's happening inside. So we done retrospective scans, and we done some reconstructions. So this is before we did the ECG editing. You can hardly tell that how well is the vessel in LAD and LCA and the RCA. Even the CPR, we can see anything. But after some time, we did the editing, and we can see that the LAD caliber and also most of the RCA. Now, I think sometimes arrhythmia patients is really challenging, but it doesn't mean that we cannot do. But if we do it, we may need to put some time for reconstructions, for editing, to get good images. And this is the CPR for the patient, that at least the patient is able to go for a further opinion. So some take-home message for today. CTA has actually an effective and alternate solution for coronary artery evaluation. And also is a very quick, precise, and less invasive, fast recovery examination for our patients. It has high sensitivity and specificity. But for me as a radiographer, I think careful patient preparation is really a key for successful scan. And you always choose the optimal protocol so that you get diagnostic value images to help the patients and the doctor. And these are my reference for the details that I have shown to you. And thank you for your time. And I hope you benefit from the presentation. Thank you.
Okay, hello. Thank you, Ms. Wong, for such an informative speech. And we will have the Q&A session at last after the second speaker. So don't let's go quickly. Now let's go to our second speaker. It is also from Macau. Is Mrs. Norman Cook. Is also the member of Macau Radiological Technologist Association. Her topic is coronary computer tomography and angiography techniques in GE revolution CT. So now let's welcome Mr. Norman Cook to give presentation. Thank you.
Hello everyone. Today I'm going to talk about CCTA techniques in GE revolution CT. This is my outline. I will talk about the purpose of CCTA, the concept of cardiac cycle and ECG, introduction of our scanner GE 256 live CT scanner, and our CCTA procedure, ECG gating and snapshot fix function of the CT scanner, our injection protocol, and finally, I prepared some cases to share with you. In conclusion, the purpose of CCTA is to provide a motion-free volumetric data during peak coronary arteries enhancement and provide an optimal visualization between lumens and artery status with minimized radiation dose and contrast dosage. Factors that influence image quality, including technical factors that we can control and patient factors that we cannot control. Technical factors include temporal resolution related, which is when is the best time for the scan, spatial resolution related, which is rotation time, KV, MA, and so on. Contrast resolution related, the velocity and the amount of contrast you use. And radiation dose. Patient factors include patient size, heart rate, cardiac output, venous access, and breath hold. All the factors influence image noise. That is the factor we can quantify the image quality. Studies suggest that image noise index should be below 30, and in our scanner, the noise index should be below 31. And now we go to a brief review of the cardiac cycle and ECG. Cardiac cycle is the performance of human heart from the ending of the one heartbeat to the beginning of the next. You will see a PQRST wave of a cardiac cycle. In the P wave, the atrium contracts and the blood goes into the ventricles. The QRS complex is the contraction of the ventricles. The blood is pumped out of the heart. And the T wave is the recovery wave, prepare for the next cardiac cycle. And there are 4 ECG shows a normal heart rate waveform and fast heartbeat, a slow heartbeat, and an irregular heartbeat waveform. So we should know the diastolic phase is at the P wave, the QRS is the systolic phase, and the T to the next P wave is the diastolic phase. During the diastolic phase, the motion of the heart is minimal, which is the optimal timing to perform scanning. Thus, in the following, I will introduce what techniques to catch up the diastolic phase to perform the scan of the heart. And here are some abnormal ECG patterns. If we encounter this kind of patterns, please be alert of the scanning parameters and the patient virtual life conditions is okay or not. If the patient is undergoing cardiac ischemia, the T wave will be inverted. If the patient has an acute of recent ischemia, the ST evaluation can be seen. If the AF situation, the P waves cannot be seen. And there is an interesting study show the cardiac motion strength in the cardiac cycle. From the left chart, the horizontal scale is the motion strength. The vertical scale is the time in percentage of hour-to-hour cycle. You will see the magnitude of the cardiac motion strength is the less in 45% and 75% of the hour-to-hour wave cycle. 75% is mid-diastolic, 45% is end systolic. And where in the right chart, it shows the cardiac motion strength in the other scale. The red part shows high magnitude of the motion strength, and the blue indicates low magnitude of the motion of the heart, which is also indicates 45% and 75% of hour-to-hour wave cycle. So let's have a brief introduction of our CT scanner. Our GE Revolution CT scanner, the number of detector volts is 256. There is 1 X-ray tube. The maximum Z-axis coverage per rotation is 60 cm. Detector technology is gemstone clarity. Gantry rotation speed is 0.28 seconds. Arrhythmia arrangement strategy is identificating smart arrhythmia arrangement and ECG outpick editor. And this is our procedure. First of all, we do the patient preparation, and then the patient will perform a scalp view and ECG recording. Then scanning parameters can be determined. And then we will do a calcium score scan. After that, we will do the bullet test. From the results of the bullet test, we can decide the injection protocol, and then we can perform the CCTA scan. At the end is the image data post-processing. Recording patient's ECG is one of the important parts of a CCTA scan. ECG rhythm information will give a feedback to the scanner to calculate what time to perform a scan. A calm patient keeps their heart rate steady with a repeatable rhythm is good for a success cardiac scan. In patient preparation, we should teach and let the patient to practice breath hold. Breath hold are critical for a success scan. You can see in this box in your panel, just click the record new heart rate. It will tell the patient to hold the breath. A few seconds later, it will start to record the patient's ECG. And in your setting, it is recommended to add up a few seconds prior to the breath hold voice, and the voice instruction should be slow so that patient is breathing slowly. ECG recording of at least 5 seconds is required to gather enough data to evaluate the heart rate and variability. In our scanner, we record 7 seconds. And these are some ECG patterns that you may encounter. This is a normal waveform, and this is a noisy waveform. So you need to check the lead is on the right place or not. And then you can see here premature beats. And then this one, you will see evaluate T wave. It may cause a double trigger. So when the ECG is being recorded, acquisition time can be calculated. Suppose that the gantry rotation time is 280 milliseconds. The temporal resolution is 280 milliseconds divided by 2, which is 140 milliseconds. A real-time heart rate is 60 beats per minute. That means one beat to another beat is 1 second. That is 1,000 milliseconds. So that R wave to the next R wave is 1,000 milliseconds. Acquisition window is 1,000 milliseconds multiple 75% and then minus 140 milliseconds, and 1,000 milliseconds multiple 75% plus 140 milliseconds. Thus, the acquisition window is from 610 seconds to 890 milliseconds. Now we go into the ECG gating features. ECG record, which can feedback the scanner when is the suitable timing to do the scan in diastolic phase, and auto-gating is designed to optimize ECG gate acquisition setting based on assessment of patient heart rate and variability. Recording heart rate statistics during a brief hold can determine the acquisition setting best suitable for the heart rate characteristic of the patient. So if necessary, you can record the ECG if you need it. And these graphics show how the auto-gating works. In the first line, that is the real-time ECG trace. In the second line, there are two parts. The first part is tell the patient to hold the breath, and the second part is the ECG recording pattern. And the third part is the diagnostic scan. Sometimes the heart may have some irregular beats. So at the fifth part, provides a few seconds for irregular window length feedback to the scanner. And then in the fourth part, auto-gating will have an optimization ECG setting, and then it can do the scan. And how the system recognizes the heart rate is stable or not. To quantify, it has a heart rate variation allowance. The phase acquired within the acquisition window are only accurate to the extent that the real-time predict heart rate is close into the actual heart rate. The heart rate variation allowance ensure that the prescribed phase does not jump more than the heart rate variation allowance value. So for example, if the heart rate allowance is 3, the patient real-time heart rate is 60, system will acquire data with the heart rate in between 57 to 63. For very low heart rate patients such as 50 to 55, it may be possible to reduce the value when doing 75% imaging since the quiescent duration is long enough for acquisition. And the allowance value are from 0 to 10. And then with the patient has arrhythmia, there is a smart arrhythmia arrangement function to fix it. Automatically, we scan the exposure will occur where the prescribed cardiac phase were not successfully acquired. Of course, the patient dose will be doubled. But on the other hand, if the patient has irregular heartbeats, having two acquisition will increase the chance that at least one of the scan will miss the diagnostic need while using just the same contrast injection. And then we have another function is adaptive gating, is to avoid scanning during beats that are immediately after an early beat. Once a premature early beat was found, the system would not scan immediately. It would scan in the next normal beat. The system will delay the exposure due to early beats that most 2 times during a scan group. And then this is a reminder that 45% and 75% outpeak is the phase that the cardiac motion is the last. Scanning will be performed in these phases, but what kind of patient will be scanned in 45% and what kind of patient will be scanned in 75%? Is there some patient will be scanned in both phases? Patient heart rates divided into 4 categories. Low heart rate, acquire 75% outpeak acquisition, and sometimes known as SSF. The SSF is a motion-free post-processing function. I will tell you later on. And moderate heart rate acquired 70 to 80% outpeak acquisition. Acquired phase is a little bit wider. SSF is needed sometimes. Intermediate heart rate acquired 40 to 80% outpeak acquisition. SSF is needed. Irregular heart rate 40 to 55% outpeak acquisition. SSF is needed. And according to the heart rate categories, common use autocating profile divided into 3 groups. For the low heart rate, scan phase will be mid-diastolic, which is 75%, intermediate heart rate, and systolic and mid-diastolic, which is 45% and 75%, and high heart rate and systolic, which is 45%. If the patient needs functional scanning or the heart rate is very fast and irregular, we can use 1-beat scan. Scan phase is from one outpeak to the next outpeak. If the patient has premature early beats, the system will scan one more time in the next outpeak. But however, if the patient has many early beats, we scan is just only one time. Because structure 1 heart cycle data is from 0 to 99%. And this chart is from our CT scanner. This is the default auto gating profile. The horizontal axis is the average heart rate. The vertical scale is the heart rate rhythm. After recording of a patient ECG, the system will analyze this ECG and check this heart rate will fall into which box in this chart. If the patient heart rate is very stable, beat-to-beat will classify as stable. Beat-to-beat variation over 6 will classify as variable. If 2 or more irregular beats were found, will classify as irregular. If 4 or more irregular beats were found, will classify as highly irregular. And then now let's take a look at this setting in this blue box. Suppose the patient average heart rate is 66 to 70. Heart rate rhythm is stable. The rotation time is 0.28 seconds. Only one acquisition part is enough. The acquisition phase is 70 to 80 hour peak with full MA. Widened SSF is chosen. Heart rate variation is scale factor. The amount is 1. So the heart rate within the scale factor rating plus 1 will be scanned. Scanning coverage will be widened, but the data of the phase of post-processing will be more. Adaptive gating is enabled. Once the major bit was found, the system will wait for the next normal bits to scan. Smart arrhythmia arrangement is enabled. Once irregular bit was found, it will scan one more time to make sure enough data for post-processing. Post-processing SSF is enabled. Smart phase was chosen. And this is the 1-bit scan setting. Suppose a patient with highly irregular and fast heart rate, or the patient need to do functional scan. Let's take a look on this blue box. Suppose a record ECG with heart rate of 101 to 200 classified as highly irregular. This setting shown 1-bit scan with full MA. Widened SSF is enabled. Heart rate variation type is absolute value. FH heart rate plus and minus 5 will be included in the scan phase. Adaptive gating and smart arrhythmia arrangement are enabled. Post-processing are from the earliest to the latest. And if you don't want auto-selected gating profile, or if you find the selected auto-gating profile is not suitable for your patient, you can design your own setting. You can just click here and then turn it off, or select another profile. Just set it manually. And then you can also choose which percentage to do the scan and the MA. And now we go to the reconstruction part. When we collect the data, there are many reconstruction methods. Center phase is a recon will occur at one of the center of acquisition window. For example, 75% hour peak. Center phase all means recons will occur at all acquisition part that's above 50% peak MA. For example, 48% and 75%. Earliest to latest. A multi-phase recon within the acquisition parts that's about 50% peak MA, for example, 40 to 55% or 70 to 80% out peak. Earliest to latest all is multi-phase recon within all acquisition data, for example, 5 to 95% out peak. Smart phase is the phase of at the least motion within the earliest acquisition that's about 50% peak MA, for example, within the end systole. And smart phase all is the phase of least motion within each acquisition part at about 50% of the peak MA, for example, systole and diastole phase. And now we go to the snapshot function. It is a reconstruction feature can be utilized to reduce coronary artery motion artifacts that may occur in cardiac exam. Once you enable SSF function in auto-gating setting, after the data acquisition, the data will be sent to the workstation. SSF would be done as a secondary recon. SSF is only available for single phase and center phase recon options. Appropriate cardiac target phase selected in mid-diastole and or end systole is essential for optimal performance. This is an example of a heart motion correction. You can see in this image, the coronary arteries is blurred. After SSF, the coronary arteries is very clear. I have a conclusion of the auto-gating profile. Heart rate threshold is 65. Below 65, the rotation time is 0.35 seconds. Above 65, the rotation time is 0.28 seconds. For patients with heart rate rhythm stable, irregular, or intermediate irregular, with heart rates below 65, acquisition phase is 70 to 80%. Reconstruction can choose standard phase or smart phase. And for patients with heart rates over 65, acquisition phase will be 70 to 80 and 40 to 60. Reconstruction chosen smart phase. While patient heart rate rhythm is highly irregular, acquisition interval is set to be how many milliseconds after the effective hour peak is mid-systolic or end systolic. And after we know how the acquisition procedure, we come to another important part, the injection protocol. The aim of CCTA is to provide a motion-free volumetric data during peak coronary arteries enhancement and provide an optimal visualization between lumens and artery status. In the old time, when we were still using 64-size CT scanner, we need to know the patient BMI in order to decide it, conscious volume and velocity. Is that the faster velocity and more volume of the conscious is the best? Because we used to do 5 cc per second, the injection velocity. And now we totally changed that. Here shows you 3 pictures of classification, including non-calcified, partially calcified, and calcified. Our aim to perform the conscious scan is to distinguish abnormal parts from the images. In our experience, the attenuation value of coronary arteries fall between 300 to 500 XU will provide enough image quality and diagnostic images. So how to set up the injection protocol is suitable for the patient? Here, first of all, we need to know which factor will affect the attenuation value. The patient factor include the patient size, cardiac outputs, and so on. And the next is the KV. In our scanner, a 256 CT scanner. When we perform the scalp view, according to the patient size, the scanner will generate an attenuation map and suggest a suitable KV value for the patient. And the contrast attenuation value will be different under different KV value. According to this characteristic, we can decide the contrast velocity and volume that is suitable for the patient. So different KV needs different velocity for the contrast agent. The method we used to calculate is the Bullet's test. The reason we are still using the Bullet's test is that the patient can experience the feeling of the conscious being injected, and we can calculate the exact volume that is enough for the enhancement of the coronary arteries. We use warm Upamil 370. The contrast volume in the Bullet's test is 20 ml. The scanning level is 1 cm below the carina. We place an RI in the aorta. If the patient needs 100 kV, we use 3.5 ml per second to do the Bullet's test. If the patient needs 120 kV, we use 4.5 milliliter per second. If the patient needs 140 kV, we use 5.5 ml per second, and followed by 20 ml saline. After the Bullet's test, we would know the time at the peak enhancement occurred. We measure the attenuation area of the ROI in the peak enhancement images. If the value is below 250 XU, we would add up the injection rate by 0.5 to 1 ml per second in the CCTA scan. If the value is over 350 XU, we will decrease the injection rate by 0.5 to 1 ml per second in CCTA scan. As we know, the peak enhancement timing for the bullet test, we add up 4 seconds and set it as the delay time of the CCTA scan. The volume of contrast agent can be calculated according to the beginning of the enhancement and the peak enhancement results from the bullet test. We would also inject enough saline in order to flush out the extra contrast in white ventricles. You can also record the ECG if necessary before the CCTA scan, and the scanner will suggest a suitable auto-gating setting for this patient. We should also notice the noise index, which is below 31. If the value is larger, maybe we need to adjust the scanning parameters in order to fulfill optimal image quality. I have prepared some cases to share with you. First, I will share 3 cases that related to the injection rate. This is a case that is the patient need 100 kV. The injection rate in bullet test is 3.5 ml per second. The acquired attenuation value of ROI in aorta is 531 XU. Thus, the concentration of the contrast agent is too high. We decreased the injection rate to 3 ml per second in CCTA scan. Contrast volume is 30 ml, and in the end, we got a XU value of 358 XU in coronary artery. And this is the second case, which is 120 kV. The injection rate in bullet test is 4.5 ml per second. The acquired attenuation value of ROI in aorta is 136 XU, which means the concentration of the contrast is not enough. So we add up the injection rate to 5.5 ml per second in CCTA scan. Contrast volume is 44 ml. In the end, we got attenuation value, which is 354 XU in coronary artery. And the third case, which is 130 kV, the injection rate in bullet test is 5.5 ml per second. The acquired attenuation value of ROI in aorta is 310 XU. Thus, the concentration of the contrast agent is enough. We use the same injection rate as bullet test in contrast scan. Contrast volume is 60 ml. And at the end, we got a XU value, which is 334 XU in coronary artery. So far, I have done some statistics with 10 cases that we done recently. Every cases after the bullet test, we found out 6 cases that meet the prediction that no need to change the injection rate in CCTA scan. And 3 cases need to increase the injection rate in contrast scan. 1 cases need to decrease the injection rate in contrast scan. And finally, all the 10 cases, the attenuation value of coronary arteries fulfill the range of 300 to 500 XU. And now I will show you 2 more cases, which is about the heart rate stability and the radiation dose. In these cases, the patient's heart rate is stable. The record ECG showed average heart rate was 57. The variability was 4. In contrast scan, the average heart rate was 57 also. The variability was 4. In this case, the acquisition phase is 75%. Radiation dose, the DLP is 36.66. And then this is another case. The patient had arrhythmia, but we looked at the record ECG first. The record ECG showed the average heart rate was 65, with maximum heart rate of 68 and minimum of 67. Variability was only 1. From this record ECG results, the scanner would suggest a stable rhythm auto-gating profile. But in the real-time scanning, the real-time ECG found out some irregular heartbeats. The average heart rate was 65, Variability was 17, irregular heart rate was 2. So in this situation, smart arrhythmia function was triggered. Repeat scan was performed. 44% was led to perform the optimal reconstruction. And in this case, the radiation dose was much more than the stable rhythm case. The DLP is 242. And finally, I would want to mention some pitfalls. Once, if you encounter a very strong patient, it needs a high kV and MA, the scanner needs time to cool down between series of scans in order to reach maximum capability to maintain optimal image quality. So it is better to control the patient heart rate below 65. Thus, the rotation time can use 0.35 seconds. The noise index can be lower. And now we come to the conclusion. Patient preparation is one of the most important parts of a success CCTA exam. A calm patient keeps the heart rate steady with a repeatable rhythm is good for a success CCTA scan. Beef hold is necessary too because it will minimize the patient motion as well as the cardiac motion. We understand the ECG and relationship of the auto-gating. I think it will benefit for our daily workflow. Monitoring patient ECG pattern, keep recording patient ECG if necessary, since the scanner would suggest an up-to-date auto-gating profile to your patient. Stable and low heart rate will lead to a lower radiation dose and better image quality. And careful conscious injection protocol will benefit the patient with optimal patient dosage of the conscious media and optimal image quality in the CCTA images. And this is our reference. Thank you for all your attention to my speech. I hope you can understand more on CCTA scan and it helps you on your daily workflow. Thank you.
Okay. So thank you, Mr. Low for. Okay, thank you, Mrs. Low, for such an informative speech. Later, we'll have a Q&A session for our audience. Any questions from our panelists to our two speakers?
Okay, then I ask the first questions. The question is the same for the two speakers. I want to know about if the patient have a fast heartbeat with a irregular heartbeat, how does your machine cope with this issue? How you can do that? Can you explain about that?
Okay, our first speaker, Ms. Wong. Ms. Wong, are you here? Ms. Wong, I think you need to unmute yourself. Okay, Ms. Wong.
Hello, can you hear me?
Yeah, I can hear you. Yes.
Okay. So for our machine, actually, we don't really see a lot of arrhythmia patient in our procedures because actually arrhythmia patients only about 10% of all our CCTA cases. But if there is a arrhythmia patient, we always see whether it's a regular ectopic patient or whether it is a irregular ectopic patient. Regular means every maybe 10 beats, only 1 beat is arrhythmia. And if it's irregular, means maybe 100 and then come to 30 and then 40 and then 60 and then 100 again. So this kind of patients, if it's ectopic patients, is regular ectopic patients where we'll still do prospective. So there's no much of changes. But for irregular ectopic patient, we will do retrospective. But still, we will ask the cardiologist to slow down the heart rate if it's possible. If it's not possible, then we will proceed with retrospective and open up the segmentations. But of course, if you open up the segmentations, means you will have radiation penalty, and the table pitch will be slower. Did I answer the question? Yeah.
Yes, I know. So,
yeah. Okay.
So my question is to want to different. Okay, this topic is use different machine. One is the Canon, in another is the GE. So let second speaker, Ms. Law, to answer the question first. Loretta, please.
Yes. Hello. In a scanner, we have like if the patient have a high heart rate and have arrhythmia, we have two parts. I can share the slide with you again. One of is adaptive gating. Will scan one more, wait for a normal heartbeat to scan. And then the other one is smart rearrangement. We scan one more time to get enough data. And the second part is reconstruction. We have a snapshot phase function. It will minimize the motion artifacts.
That's all?
Yes, that's all.
Okay, so I saw the GE and the Canon is using the different type to solve the problem for the first heart rate. Like a Canon to use the segmentation. First, because we know the challenge when the patient have the first heart rate and under control by the medication to low down. So in the Canon, need to use segmentation type. And the GE not have segmentation, just only use the software to reduce the motion artifact, right? And about the irregular, like arrhythmia or irregular heart rate during the scanning, so the GE have some AI function. They can track and detect the normal beat, and then we have some protection, and then we scan again, so the dose will be double. So the big challenge is the first heart rate. Today we have two type of scanners, the brand, I mean, the one is the Canon, the another is the GE. So we know we also in the market have a Siemens, have a dual source. So when you are dual source, that means the temporal resolution will be very short. Because the temporal resolution is the most important for the CPTA, because when is the very first heart rate, the temporal resolution must be very short. So if you not enough short, so the image will be blurred. Okay. I not have more question. I don't know others.
Yes, I have a question. Yep, I have a question. The first, I want to say thank VT Healthcare in Vietnam and Bagi Healthcare in Vietnam. Support for Asia CPD group. One webinar very good, very well. Now very good. I would say one behalf for Asia CPD. Thank you, VT Healthcare in Vietnam and Bayer in Vietnam support for us. I have a question for Jeng Wong.
Yes.
I think if patient under 15 years old, We can skip this calcium score. Okay, the first. I think my experience, I will share with you. Patient under 50 years old, we can skip the calcium score. We low dose for patient no radiation. The first, and I think I want to talk with in Canon and in next in Indonesia, in Julian will introduce for everybody. I think the next we talk about in spectroscopy. I don't know in Jeng Yeng Wong, you know it, spectroscopy for coronary in better in imagine in result, but imagine it may be better or not better. Yes, the second. You understand the second question?
Okay. I see whether I get you right. Okay. So the first one is you say that in your country, if it's above 50, if it's below 50 years old, is it? Below 50 years old, that you skip the calcium score, is it?
Yes, like a Edwin.
Okay. Too young to do it. I think this is depends on country and also the cardiologist, because some cardiologists thinks that the patient might have a family history of hypertension, or in their family history there is AMI history, then they wanted to do the calcium score. But I know some countries they really skip calcium score for patients below 40 years old.
Yes.
Yes, I think so, because probably they think that there's no point of doing the calcium score and more radiation is given. Okay. Yeah. So, but the second question, I think I may need you to repeat a little bit about Canon. The second question, yeah. Is it some software from Canon?
No. Now I know in Canon have a aquarium frame.
Yes, a current frame.
Yes. The new West. How about in coronary? You check in coronary in your city now and the new West. We use a spectroscopy. What is the difference?
Yes. I think it's different because I think Prime is doing better, because Prime actually has a better radiation dose saver in it. We call it the first. Okay, for the old version that we're using is AIDR 3D, but for the new version that has the first, they call it the first, which is faster. And for their scans, I think they can even do scans faster and cover more areas than the old version. So, and also now for CCTA, I think they are not just doing CCTA itself. They are also doing something like, in coronary angiogram, they have IVUS, the IVUS that they put the tube in and to check whether there is stenosis. I'm not sure whether you all know about it, but in CT, they have this CT-FFR, which they can do it similar to IVUS for the cardiologist to actually check whether there is a need to go for a re-scan, or actually go for probably they want to do PCI for the patient. So I think for new CTs, they have more software, and they can actually do better scans and faster scans. Of course, I'm not using Prime, so I'm not very sure about what Prime doing. Yeah.
Yes. Yeah. I think that now in everybody focus the spectroscopy and do also do energy and spectroscopy. Everybody, it is not so far in 3 and 5 years. Next 3 or 5 years, everybody we change to in generation, the new generation. Yeah. Okay. I think the second question for Minggu LO. I thank you so much. You recommend for everybody. You recommend for everybody reconstruction. It choose the ECG smart phrase. Very good, very important. My experience in reconstruction, for it choose the ECG heart rate, very important if you want to success for in corona, you check for coronary for patient. My question for you, you use a smart phrase every patient.
Smart face is not needed in people. Smart face like a is will automatically faces is the less use that face for instruction. It's just like a technology in GE CT scanner. Patient have full hardware reader.
Okay. Okay. I see in Q&A have one question very good. If I think very good. It would be a question. For example, one IT moderator every you check in some question in Q&A very good. How many contrast media you live with? Patient came 106 kilogram. In your experience, you check in Q&A. Many questions very good. The first, I think the good question. How your experience? How in they have a patient? They have a patient heart rate 80 more to 80 kilogram. How you choose reconstruction for patient?
Okay, for patients with heart rate about 80 to 85, I think
cannot lower. Yes. The one question in Q&A they post very good.
That means as questions on the question box, the patient is very heavy, so is 125 kilogram. So how to use the contrast media for this patient? How you control? The question is this. So how many cc per second? The total volume, the patient is very heavy, is around 120 kg. The question about that.
I saw one question is patient is 160 kg.
Yeah,
60 or 120. Right. 160.
The one and only patient I've scanned before is 120 kg. We gave until it is a foreigner, so we gave 7 mil per second. Yeah, 7 mil per second. But our contrast we still control below 100 because the patient is quite the heart rate is quite stable. But the flow rate is higher, so you actually, if you are possible, you can get a gray granular, but I think it's very difficult. So if a green, I think you can still do it to 7 mil per second. Yeah.
Okay.
Yeah.
So the cannula is very, very high.
Yeah.
Very big cannula for the injections.
Yeah, but the images is still quite good. Still quite good.
Okay, and I will try to answer the GE. So Loretta, to say we use the bolus test. So during the bolus test, we can calculate the how many cc per second will be used. So if the patient is heavy like 160, we will do the same test. I think that patient we need to use the 140 kV because it's very high, very big the body. So you know when the kV is high, the attenuation will be affect the attenuation of the contrast. So I think like a 6, 7, we do the test first, and then we'll calculate how many add or reduce or increase. So we will do that. But we never do the patient like that 160. And then I think 120 is in the Asia is a very, very big.
Yes,
I think
yes.
more experience in Europe or in America. So we had a lot of experience about the patients like 160 kilograms.
Yeah. Have a one question for Fernando. One I see in Q&A. One in audience they ask you they want to PDF file because I think very long in lecture today very long. They cannot understand enough, not enough for understand. They have a question. They want to get a PDF. How about you? But I think that now we send for them, we transfer to tip. I think the audience can see, can link to in YouTube. I think they're very good.
Yes. So the audience can
audience.
try to review this video on the YouTube.
Yeah. For
Because
example, I cannot remember.
Because some audience asking about can share the PPT, but I think this is a private, so I think you can review in the YouTube is better. So I already reject. Also, some audience to ask about the audience list. So it is the privacy. So we also cannot provide. Okay, tonight time is going 9:30. Maybe we'll be see you all on the second.
Okay.
Mr. Sukianto.
Yeah.
So will be passed to you.
Yeah.
Okay.
I think in 10th of January.
10th of January. Okay.
Yeah.
Will be announced before.
January.
Yeah.
Yeah. I order for you. I book for you. You focus a topic in MRI or CT. CT you focus in spectroscopy or neural energy. We can invite.
Okay.
Yeah.
Neuro. Okay. Good advice.
Tonight.
Yeah. Thank you,
tonight,
everybody.
Have any more? No more. We will say good night all, and thank you very much, and see you all on January. Thank you. Goodbye. Good night.
Thank you.
Thank you, everyone.
Very well. Thank you. Very good.
It's excellent.
Bye-bye. Night. Good night.
Good night.
Yeah. Thank you.
Good night.
Thank you.
Bye-bye.
Good night, Luna. Good night, Luna.
Selamat malam. Selamat malam.
Maraming salamat po.
Selamat po.
Thank you, speakers. Thank you, MSRT.
Excellent speakers. Thank you very much. Yeah.
Thank you.
Thank you. Bye-bye, Preskin Mountain.
Bye-bye.
Bye-bye, Wisman Kuok. Bye, Sir Kim Mountain. Bye-bye.